Right, hi, I'm Ross Fairgrieve. I'm a full-time paediatric anaesthetist at York Hill. I'd like to thank John tonight for asking me to come in and talk a little bit about our chronic pain service. Now, I wasn't quite sure of the remit of this chat tonight, and I'd been involved with a couple of emails with John, but I decided that we're probably quite a niche specialty and you might not know too much about what we do and how we operate. So I thought I'd explain how the service was set up, how it currently functions, and then maybe talk about 4 or 5 specific and are probably most common patient groups, so you have an idea of what we do and what we tend to do about them. I haven't gone into too much depth with regard to physiology or pharmacology, but there should be plenty of time at the end to have a chat about anything you're not sure about or anything you'd like to talk about specifically. We have approximately 100 new patients per year. On the Thursday afternoon clinic, we see 12 patients, 6 patients at the multidisciplinary clinic, and on average about 4 patients at Ashcraig. I'm going to talk a little bit later about the type of patients we see and what we do about them. In the meantime, I'm just going to talk a little bit about some of the treatment modalities we use. They'll be familiar to most of you. We'll talk about them and reference the specific groups later on. So, hypersensitivity and abnormal conduction. These are very common after, well, certainly not very common, but they're common after injury, and probably represent one of the more common mechanisms for patients to present at the chronic pain clinic. Complex regional pain syndrome. We are a national centre for paediatric referrals for this condition. The vast majority of our complex regional pain syndrome is type 1, which is pain involving, well, pain essentially out with the site of injury and not involving a nerve, but it has often much wider sort of sensory, autonomic and motor disturbances that you wouldn't necessarily associate with the injury. We don't see phantom pain very much now. That's associated generally with amputation, and that's something that hasn't really happened in paediatric orthopaedic practice for solid tumours for quite some time. There are very occasional amputations, but by and large it's not something that we see very much of now. Pain of chronic disease, that's probably the second most common mechanism, and it's multimodal actually. We have all sorts of kids coming in with different chronic diseases, from high permeability to various renal problems associated with pain, to complex needs kids who are wheelchair bound or who are post surgical. We also have a number of kids who come via gastroenterology with various complaints, which I'll allude to a little bit later on. So I'd like to talk just briefly about treatment modalities. Pretty much all of our chronic pain patients, and this I guess would apply to adult services as well, they're all managed in a team approach. Our first line therapies would be simple, we say non-invasive, but acupuncture is probably pretty invasive actually, but simple, harmless and non-pharmacological. So wherever possible, if we have a reason to use acupuncture, TENS or TSE, we will. You maybe not heard of TSE before. It's transcutaneous spinal electroanalgesia, and it looks a bit like a TENS machine, but it works at a much higher frequency. It's actually been proven to be quite useful in children, but not in adults, and particularly for visceral type pain, but not for peripheral. So for your average TENS application, if TENS is useful for things like limb pain or muscle girdle pain or back pain, TSE is not appropriate for that at all. It's quite good for abdominal syndromes or pelvic pain. Not useful in adults. We've got a problem at the moment with this because the machines that we're using are no longer manufactured, so we're currently in short supply. We I think have probably 6 or 7 of these left, and no way of supplying them in the future, I don't think. Pharmacological methods, we use the gamut of neuropathic medicines. Probably the commonest we would use would be gabapentin. We also use lamotrigine, carbamazepine. We can talk a little bit about these at the end. And local anaesthetic techniques and blocks if required. Usually these patients would be done in a blocking session. We have one of these a month on a Friday morning, and if that's not appropriate, then we'll bring them into an emergency theatre slot and try and do them through the rest of the week. Sympathetic blockade. This has traditionally been used, I think, for treatment of complex regional pain, and it's not something I've ever been trained in. And latterly, John Curry, my predecessor in his last few years, I think, was maybe doing one of these blocks every 3 years. So we currently have governance issues with this kind of block, and I think if I did have a patient who required it, then I would have to be looking for help from out with the hospital, presumably from an interventional radiologist who has some experience of this now. In the last, well, certainly in my experience doing paediatric chronic pain, I've never had to refer anybody for one of these blocks. Okay. So I think probably the most important principle when it comes to managing these patients is a full and frank explanation. Give as much information as you possibly can and reassurance to the parents and the child. I mean, one of the big problems with a lot of paediatric chronic pain is there's just a huge amount of anxiety associated with it, particularly from the parents. And if they've had pain for a while, we quite often find it useful to create an event and break the cycle, and that might involve something as simple as an admission to hospital overnight for administration of a medication. Sometimes that's all that's required. So from a functional point of view, what we're really aiming for is school attendance. I think that's the single most important factor when it comes to treating these kids, getting them back to school. And it's not only about academic performance, it's also about the ramifications being absent from school can have on peer relationships and breakdown of friendships and the like. The other issue with school, though, is it can quite often be problematic for medication administration, and we get that quite a lot from families. I mean, some schools are very supportive, but others, particularly the bigger ones, it can be a big issue. So on top of that, we also need to try and make sure that these kids are socially, functioning as normally as possible. Making sure that they're seeing friends, and that if we possibly can, getting them out and doing normal things. The third thing, obviously, is sleep. If you're not sleeping and you are sore, you wake up in the morning, or you don't wake up in the morning, you've been awake all night, then the whole cycle just gets a whole lot worse. So school, normal social functioning, and sleep. So what I'm going to do now is just chat probably about 3 or 4 of the commoner patient groups that we see. Probably the commonest group would be complex needs children. Now, there's a huge spectrum of disability with these kids. Some of them are physically disabled, some of them are pretty physically and mentally disabled. An assessment of pain can often be incredibly difficult. We're often, with the more developmentally delayed children, very reliant on the parents for a history, and quite often there's not much history. It's just, Johnny was just he's just not being himself. He's just making a lot of noise, and we're not really sure what's going on with him. Quite a lot of these patients obviously are wheelchair bound, and I reckon certainly from the ones that communicate, that seems to be the root of the vast majority of their pain. They've got joints that are they're made for walking and bending and stretching, and they're not made for sitting in a chair all day. So they present with back pain, hip pain, knee pain. Some of them have been in the hands of the orthopaedic surgeons and may well have had surgical procedures, particularly in their hips, and can also present with post-operative pain syndromes. And then you've got spasticity, which is very, very common. the vast majority of these kids, if they are spastic, seem to be on baclofen, and by and large that's managed by the neurologists. The next issue we have with them is feeding. The more developmentally delayed kids quite often go on to require fundoplication for reflux, and they can often end up with dysmotility problems and feeding issues which can result in fairly intractable abdominal pain. From a modality point of view, if we take the kids who have just basic, my hips are sore, my back's sore, my knees are sore, two modalities that are most useful in the first instance would be application of TENS machines, acupuncture. Particularly with hip pain, they quite often get referred pain to the knee, and they'll tell you that there's a trigger point, it's right there. And quite often, believe it or not, trigger point acupuncture is incredibly useful for these. If on the off chance that neither of those modalities are helpful, then gabapentin in a relatively small dose can be a very useful drug, and it might only be 100 milligrams in the morning and something like 200 milligrams at night. Quite often that's all that's required for these kids. We normally give them a dose, have them on a maintenance dose. They come back to the clinic maybe a month, 6 weeks later and say, oh, that's great, I'm sleeping better, I'm much more comfortable. For the kids who have dysmotility, that can be a real pain in the neck, and it's a very difficult treatment, pain to treat. We've tried TENS in the past with little effect. From a pharmacological point of view, the most effective drug seems to be lamotrigine. We're not entirely sure why it works. It's a sodium channel blocker, but it seems to have some effect on the visceral hyperalgesia syndromes. So that's our commonest group. The next group would, generally speaking, be referred by rheumatology. They're hypermobility. Often a very difficult group to treat. They've, because it's seen as a relatively benign condition, they've often come having been tried with many analgesics over the course of time. The mainstay of therapy, from our perspective, though, seems to be physiotherapy, TENS and gabapentin. I would suspect, though, that in about 60 to 70% of these patients, there really is not an awful lot you can do for their pain management, and it then lies in the hands of the psychologists to teach them some coping mechanisms and to get them to accept that it might be lifestyle modification that's required rather than any sort of magic wand or magic pill. Right, functional abdominal pain syndrome. This is the pain of my life, because we're seeing a huge number of patients coming to the clinic now with what seems to be functional abdominal pain. It's chronic recurrent abdominal pain, not due to any structural, organic or metabolic disease. It needs to be present in general for more than 6 months, and to be honest, the vast majority of patients who come to the clinic have probably had it for in the region of about a year. It's very distinct from abdominal migraine, irritable bowel syndrome, epigastric pain syndromes or dysmotility disorders. It's constant. It doesn't wax or wane. It's not associated with eating. It doesn't affect their appetite, doesn't affect their bowel function. It may also be associated with some other somatic symptoms such as headache or limb pain. And peculiarly, it tends to affect a very specific cohort of patients. They tend to be, in the main, female. They would tend to be either preteen or early teens. They're generally bright, highly motivated children who have done well at school, and the clinical picture is that they present with a viral illness usually, and it's usually a sore throat or a cough or a cold or something, and they go on to develop some abdominal pain that mimics appendicitis. And a good number of them come in being treated conservatively for appendicitis. They settle down, they go home, but the pain persists, and it's usually central, sort of periumbilical pain they get. A number of them go on to have laparoscopic appendicectomies, and the appendix is usually normal. But it's an awful pain, because it has so much of an effect on their life. Not really entirely sure what causes it. There's been some suggestion that there's an abnormality in the enteric nervous system and some abnormal bowel reactivity to physiological stimuli. So generally speaking, they would come via the gastroenterologist, who would have excluded the usual inflammatory bowel disease, peptic ulcer disease, all of those things. From a treatment perspective, we're just about to set up a sort of functional abdominal pain clinic, because on average we're probably seeing, I guess, maybe 2 of these cases a week now in our chronic pain clinic. And I think from the very early stages we need to have psychology involved. Now, I reckon we probably can help around about 40% of these cases and get them back to a relatively normal existence through either pharmacological or interventive means, but the other 60% we're really relying on psychology services to help them. First line therapy, generally speaking, would be transcutaneous spinal electroanalgesia. So we give them a TSE machine away with them, explain how to use it, and probably in about maybe 10% of that group they would come back in a month or 6 weeks and say my pain's much better. If that doesn't work, we then bring them into hospital and we start them on a small dose of lamotrigine. Now, we're using lamotrigine in this patient cohort off licence, so we're tending to bring them in really just to find out whether or not they develop a rash, because if they do develop a rash, we stop it, and it does happen in a reasonable number of patients. So they come in on a Monday night usually, they have some lamotrigine at 8 p.m, then a following dose the following morning, and they're discharged the next day on an incremental dose. And for your average patient in this age group, it would normally be a 25 milligram BD maintenance dose. If that doesn't work, we increase it to 50 milligrams BD. Now, during all of this, we'll have psychology involved. The next stage, if they're still not any better, would be admission for a ketamine epidural. Now, we have a fairly reasonable number of anecdotal cases where this has been beneficial. So we bring them in on a Monday, fasted, and pop in an epidural with a low dose infusion of bupivacaine or chirocane, L-bupivacaine, over the course of the week, accompanied by low dose ketamine. And they get a bolus of ketamine epidurally on the Monday and low dose up until the Friday. If on the Friday they're better, well, even if they're not, the epidural comes out and we let them home. What we've found over the years is that probably somewhere in the region of 50 to 60% of our patients respond very well to this treatment, and may, usually after the first epidural, would experience somewhere in the region of 4 to 6 weeks of pain relief. They come back for a second epidural, the pain window extends, and by the third or the fourth, we've usually got to the point where we're referring them on to the adult service, but they've been functional for a good bit of time. Small cohort of them don't do with this at all and end up having to just learn coping strategies with psychology input. Okay. The next big group of patients, I guess, would be orthopaedic syndromes. We get a lot of hip disorders, scoliosis and post-surgical and fracture pain. A lot of these guys are actually referred to us really quite soon after surgery, so they wouldn't necessarily be chronic pain patients. They're still in the throes of acute pain and are still on their normal acute pain medications, albeit quite often not appropriately prescribed, or perhaps appropriately prescribed but not appropriately taken. Scoliosis, we see quite a lot of pain from scoliosis, although we don't currently at York Hill do any surgery for this. The scoliosis service has all gone over to Edinburgh. I think it went there about 6 or 7 years ago. But obviously there are a cohort of patients who are in the west of Scotland, and their pain follow-up is done through our clinic. And we see a good deal of post-surgical and fracture pain. The vast majority of these kids do respond to a neuropathic medication, and our first line in this instance would generally be gabapentin. The next group of patients we see a surprising amount of would be scarp pain. It's relatively common, it's quite easy to treat. Our first line would be acupuncture, and in the same way as we have, with the functional abdo pain, we get the epidural in a pain-free window, and then a second procedure in a longer pain-free window. Acupuncture seems to work the same way. We generally just ask the patient where they're sore, get them to point to needle the area. Generally speaking, we find they might get a week or 2 weeks of pain relief. They come back for another needling. The pain-free window generally extends maybe 3 or 4 months. It's just kind of arbitrary, but normally after the second, the window's extended. They come back for a third time, after which the pain has gone. Occasionally we resort to local anaesthetic patches because acupuncture doesn't work 100% of the time, or local anaesthetic and steroid injection. So those are the conditions we see mainly. We do have another few that I haven't talked about specifically. Complex regional pain, as I say, we're a national centre for referral for paediatric CRPS, but we don't see a huge amount of it. Post-chemotherapy pain, either neuropathies, which would need some neuropathic medication, or quite commonly we're seeing avascular necrosis, usually of the hip, in response to chemotherapy. Now these patients often become opioid dependent, and our general concoction would be a combination of MST and Oromorph in the paediatric population. Headache, we see a reasonable amount of headache, various causes. We do have a headache clinic in the hospital run by a Dr. Abu Arafi, who I think is a paediatrician out in Forth Valley, but he does a headache clinic once a month. We don't have any specific input, but if he feels he's not able to manage the pain from headache, then he would refer them to us. And the most effective modality of treatment we've found for headache has been acupuncture, surprisingly. We see a good number of patients with venous malformations in various places and of various sizes. These guys typically present with sort of hot, throbbing pain, which by and large stops them sleeping. That's usually their main complaint, and they respond very well to carbamazepine. We see a good number of atypical facial pains referred from ENT, and with regard to what you do with them, we've tried various neuropathic medications. First line would probably be the way you would treat trigeminal neuralgia, and that would be with carbamazepine. Quite often it doesn't work, and it's about chopping and changing until you find something that does. The next group of patients would come from our urology colleagues, atypical pelvic or perineal pain, and I don't know where I learned this, but application of a TENS machine to the posterior tibial nerve is often a very simple and effective mechanism for treatment of this pain, and it must produce a feedback loop, but anyway, it works pretty well in a reasonable number of these patients. The last group of patients, quite difficult to treat, and over the course of their childhood they end up really becoming quite unwell and often die before they're teenagers or in their early teens. Epidermolysis bullosa, in its severest form, it presents at or around birth and is almost always requiring opioids, and these kids really just come to the hospital every now and then for various procedures. We're often involved with anaesthetising them for venesection, for bloodletting. They develop an anemia of chronic disease, they quite often develop infections, they need long-term intravenous access, and along with that they are really, really sore. So we're quite often involved in their perioperative opioid management as well as their requirements when they're out of hospital. So that's where we are really. That's what we do. That's the kind of patient group we see. Currently, well, since John's retired, I think we're going to see some changes in our service. I think John was quite protective of it. You know, obviously with managed clinical networks now, I think we're going to be integrating with adult services, particularly with a view to better transition of our adolescent group of patients. I think York Hill as a hospital has had an arbitrary cut-off of 13 years of age for patients, but a good, I would reckon, somewhere in the region of 30 to 40% of our patients fall out with that age range. They're 13-year-olds and above. So they're still at school, and you know, psychologically they're still children, and very many of them have medical and surgical conditions that have been treated since early childhood by our physicians and surgeons, and there's a desire, I think, to have ownership of these patients. So we are certainly we're able and happy to keep them up until they're about 18 or so. But our wards aren't quite so happy. The nursing staff aren't quite so happy. So I think we need to look to the future and better transition to adult services. Also, something we don't have in Glasgow at the moment for children and adolescents is easy access to a pain management programme. And my understanding, correct me if I'm wrong, Jonathan, is that there's one being set up in the Templeton Centre, I think. Currently, if we have patients who we need to have referred to a pain management programme, then our option is Bath, which is pretty inconvenient for everybody. Okay, so I'm going to end it there and I think open the floor to some questions.